My name is Ho-Sik Shin from Goshin University Gospel Hospital. It is because of God's extra help that I'm able to present at this precious conference. I would like to thank KSD for inviting me and to Professor for charity. Today's topic is navigating metabolic risk in living kidney donors. First, I give you an introduction. Observation from the animal models and the general population had led to the concerns about the long-term impact of the reduced GFR. First, in the rat model, unilateral nephrectomy plus partial ablation of the remaining kidney result in the hyperfiltration of the remaining glomeruli. And it suggests that the sustained single nephron hyperfiltration may have maladaptive consequences by damaging remnant glomeruli. In the general population, decline in eGFR smaller than a doubling of serum creatinine concentration occurred more commonly and was strongly and consistently associated with the risk of ESKD and mortality. Let's turn to long-term outcomes with kidney donation. First, there are a variety of challenges to studying living donors' outcomes. The first is identifying an appropriate comparator group. A second challenge is determining the causation of any findings. Second, there are metabolic and hemodynamic changes after donations. In prospective study, 6 months after donation, compared with the baseline, measured GFR was 29% lower in the living donors, but unchanged in the controls. Kidney donors manifested several of the findings of a mild CKD. In prospective controlled study, donors remain healthy with a stable kidney function for the first 9 years, but differences in metabolic and vascular parameters could be harbingers of adverse outcomes requiring future interventions. 36 months after donation, living donors had abnormalities of bone metabolism, significantly reduced tubular phosphate reabsorption, serum phosphate concentration, and serum 125 vitamin D3 concentrations. 12 months, living donors had significant increases in reduced PTH, FGF, and high-sensitivity CCLPs levels. In addition, detectable highly sensitive troponin T levels and microalbuminuria were significantly more common in the living donors. Third, there are conflicting reports of living donor hypertension risk. A meta-analysis study shows that nephrectomy did not increase the prevalence of the hypertension. In normal individuals, unilateral nephrectomy does not cause progressive renal dysfunction, but may be associated with a small increase in blood pressures. More recent studies of living donors compared with the controls have continued to have a conflicting result, increased risk or no difference. In this multi-center study shows that kidney donation was associated with a 90% higher risk of hypertension regardless of race. In this European study of live kidney donors and the propensity score matched non-donors from the general population, they demonstrate that the long-term prognosis people that underwent a live kidney donation is identical to non-donors. Loss of kidney mass after live donation does not translate into negative long-term outcomes in terms of morbidity and mortality compared to the non-donors. First, this slide shows the cardiovascular disease and mortality outcomes in living donors. In a meta-analysis and review of long-term living donor follow-up study concluded that the CVD and mortality were not increased after the donation. Although studies comparing living donors with matched controls found no difference in the CVD or mortality. However, most were limited by relatively short follow-up. In contrast, in 2014, Mogent reported that living donors compared with the selected healthy controls significantly increased the all-cause and cardiovascular mortality. More recently, 7 studies comparing living donors with matched controls found that either no difference between groups or decreased mortality in the living donors. This slide shows that the CKD and ESKD risk compared with the controls. 2 studies increased ESKD in living donors, but in both studies, the absolute ESKD risk was small. A major limitation of both of the previously mentioned studies is that they did not match the family history of CKD. These studies demonstrate that kidney donors are at increased long-term risk for ESKD, CV, and all-cause mortality compared with the controlled group of the non-donors who would have been eligible for donation. Compared with the matched healthy non-donors, kidney donors had an increased risk of ESKD over a median of 7.6 years. However, the magnitude of the absolute risk increase was small. A common concern with most previous studies is that there was an insufficient follow-up time. The reported interval from donation to ESKD is directly related to the duration of follow-up. In single-center and registered studies, authors report on the 66 living donors who donated more than 50 years ago. Figure 1 shows the overall cumulative instance of all-cause deaths post-donation and the cumulative instance by cause. 30% of the deaths were due to cardiovascular disease, an instance similar to that seen in the U.S. general population. In the University of Minnesota series, mean interval from donation to ESKD was 27 years. A critical question is whether living donors who subsequently developed risk factor for CKD will have an accelerated course to CKD and kidney failure. There are few data to answer this question. Weight gain was associated with increased risk of hypertension and or diabetes. In descriptive data on serial BMI post-living kidney donation, increasing BMI was associated with a higher relative risk of hypertension and type 2 diabetes. However, the weight gain was not associated with greater risk of CVD, CKD, ESKD, or death. This is the first national study to examine risk for ESKD among a cohort of the obese living kidney donation. Each unit increase in BMI higher than the 27, there was an associated significant 7% increase in risk of ESKD. Onset of diabetes in living donors was associated with the development of proteinuria and hypertension. These results indicate that the donors who developed diabetes similar to patients with diabetes who have 2 kidneys are more likely to develop hypertension and proteinuria. These results demonstrate that roughly 1/3 of kidney donors developed hypertension after donation, and the risk factor for its development are similar to what is seen in the general population. Hypertension was associated with proteinuria, CKD, CVD, mortality. I'd like to tell you risk factor for CKD and ESKD and risk calculators. Each calculator has limitations based on the data available in the data set. A calculator that could estimate long-term risk with and without donation is still needed. I'd like to tell you other long-term living donor outcomes. There was no differences between groups in microalbuminuria, instance of diabetes, AKI, hyperlipidemia, depression, BMI, cancer, fracture, or kidney stones. Pregnancy in women with CKD are associated with increased maternal and fetal complication. Thus, there have been the concern about the pregnancies after donation. Unfortunately, there remains limited data on the pregnancies among female living donors. Pregnancy is associated with the anatomical and the physiologic effect on the kidney, including hypertrophy and hyperfiltration. The data suggests that pregnancy after donation is not associated with an increased risk of a complication compared with the pregnancy in the matched general population. Let's turn to potential mechanism for progressive decline in GFR after kidney donation. First, underlying disease or disease risk that was present before donation. One possibility for progressive decline in GFR after donation is underlying or subclinical disease in the donor. Analysis of OPTN data found that only a few living donors developing ESKD had the same disease as their recipient. Kidney donor evaluation do not typically involve a kidney biopsy of the potential donors. Careful morphometric study of kidney histology from biopsies obtained at the time of donation suggests otherwise. Among apparently healthy adults, the microstructure, the finding of nephron hypertrophy, and the nephrosclerosis different they are associated with kidney function, macrostructure, and risk factors. Longitudinal investigations are needed to determine the prognostic significance of these structural findings. In the recipient of living donor kidneys, death-censored graft failure over a mean of 6.3 years was predicted by more severe interstitial fibrosis and tubular atrophy, arteriolar hyalinosis, larger glomeruli, and larger tuber in the living donor kidney at the time of donation. Subclinical nephrosclerosis, larger cortical nephron size, and smaller medulla volume in healthy donor modestly predicted death-censored graft failure in the recipient, independent of donor or recipient clinical characters. Second, detrimental impact of glomerular hyperfiltration after donation. Another possible etiology of living donor ESKD is that the resulting glomerular hyperfiltration leads to the nephron damage. Early after donation, the GFR in the remaining kidney is approximately 70% of the GFR before donation due to compensatory hyperfiltration. Importantly, physiologic modeling studies in the living donors have suggested that the compensatory increase in single nephron GFR after donation is not maladaptive. It is possible that the above decrease in renal function associated with the nephrectomy by the somewhat variable age related to decline in GFR may lead to clinically relevant kidney disease in some living donors. Living donors developing kidney diseases start off with a lower GFR than the individual with two kidneys. In this study, ESKD development irrespective of pre-donation renal function or absence of risk factor of CKD, such as proteinuria, hypertension, obesity, or diabetes. Let's turn to long-term donors care. First, counseling donor candidate. In addition to counseling about the perioperative risk, living donor candidate should be counseled about the potential long-term risk. All living donor candidates should be informed that the decision to donate should be accompanied by a commitment to a healthy lifestyle as well as regular healthy maintenance visit that the screening for early kidney disease and kidney disease risk factors. Second, long-term donor care. We have now learned that the type 2 diabetes and hypertension are the two most common causes of ESKD after living donation. We also know that treatment of new onset CKD can often slow the progression. As discussed previously herein, living donation should be paired with a lifetime commitment to a healthy lifestyle. Third, the need for the additional study. There are few data on the outcomes compared with the appropriately matched control with sufficient follow-up time to meaningfully assess the attributable risk. These data are needed to optimize donor candidate counseling and informed consent. And importantly, living donors themselves are asking for this information. This study shows that identifying outcomes that are important to living kidney donors. Living kidney donors prioritized a range of outcomes, with the most important being kidney health and the surgical, lifestyle, functional, and psychosocial effect of donation. In this single-center study of donation-related concerns, nearly all participants reported personal or family concerns regarding donation. Concern from participant social network were common and often differed from the participant personal concerns. I would like to conclude with several remarks. First, there are the concerns regarding medical risk to the donor in living kidney donation. Second, some studies report increased overall mortality, cardiovascular mortality, and kidney failure in living donors. However, the absolute risk is very small. Third, studies have not identified the risk attributable to donation. First, there remains a critical need for long-term follow-up studies. Last, donors need continued medical follow and encouragement for continued healthy lifestyle. Thank you for your attention.